Hello and welcome to my channel. Today we'll talk about adrenal disorders. And there are some conditions when there is a hyperfunction of adrenal glands and hyperfunction. For example, if there is a hypersecretion of adrenal glands, it could be cortisol for Cushing syndrome, aldosterone for primary hyperaldosteronism, or catecholamines for pheochromocytoma. And also there is some condition where there is a hyperfunction of adrenal glands, and it will be aldosterone for Addison disease and aldosterone or cortisol for congenital adrenal hyperplasia. And let's start talking about them. Cushing syndrome. It's caused by prolonged exposure to elevated levels of either endogenous glucocorticoids or exogenous glucocorticoids. And there are 5 main causes: iatrogenic for chronic corticosteroid administration, pituitary ACTH excess, it's a Cushing disease, bilateral adrenal hyperplasia, adrenal tumor, or corticotrophin releasing hormone from non-endocrine tumors. Clinical features are proximal muscle weakness, central obesity, buffalo hump on neck. Cushing face is a plethora, moon face, and acne. Weakness, hirsutism, abdominal stria, thin skin, easy bruising, hypertension, hyperglycemia, menstrual changes, it could be amenorrhea, osteoporosis, psychiatric changes, and it's especially depression. So, diagnosis: the urinary free cortisol level, the low dose dexamethasone suppression test, the evening serum and salivary cortisol level, and the dexamethasone corticotropin releasing hormone test, and also imaging. So CT scan is useful for primary adrenal pathology. If a pituitary source of excess ACTH is suspected, it's better to use MRI, and chest and abdominal CT scans should be performed in patients with a suspect ectopic ACTH production. Management of endogenous Cushing syndrome. There is pharmacotherapy, and medications are 11-beta hydroxylase inhibitor, somatostatin and naloxone, adrenal steroid inhibitors, glucocorticoid receptor antagonists, and adrenalytic agents. And the treatment of choice for endogenous Cushing syndrome is surgical resection of the causative tumor. Primary hyperaldosteronism was previously thought to be most commonly caused by an adrenal adenoma and was called Conn's syndrome. However, recent studies have shown that bilateral idiopathic adrenal hyperplasia is the cause is up to 70% of cases. Differentiating between the two is important as this determines treatment. Adrenal carcinoma is an extremely rare condition of primary hyperaldosteronism. Clinical features: these patients usually asymptomatic and hypertensive, and any symptoms they have, it's due to hyperkalemia. It's a weakness, cramps, paresthesia, polyuria, and polydipsia. Diagnosis: aldosterone will be high, serum and urine, plasminogen low, and hypernatremia, hypokalemia, and alkalosis. There is elevated plasma aldosterone to plasma renin activity ratio, it will be more than 20, and the increased aldosterone levels act via negative inhibitor to decrease renin levels. CT scan can distinguish a unilateral adenoma from bilateral adrenal hyperplasia. Surgery is preferred for patients with a unilateral adrenal adenoma, and medical therapy is preferred route for patients with bilateral adrenal hyperplasia or those with unilateral adrenal adenoma who are poor surgical candidates. Spironolactone is an aldosterone antagonist that also acts as an androgen receptor antagonist, and side effects include gynecomastia in men and menstrual changes in women. Pheochromocytoma. It's a dangerous tumor of the adrenal medulla. Clinical features are paroxysm or spells of hypertension, headache, sweating, palpitation, pallor, skin blanching, rising sensation of tightness in upper chest and throat. And the following may also occur during spells: tremor, nausea, weakness, anxiety, sense of doom, epigastric pain, flank pain, and constipation. Diagnostic tests for pheochromocytoma include the following: plasma metanephrine testing, 24 hours urinary collection for catecholamines and metanephrines, abdominal CT scanning or MRI. Management of pheochromocytoma. It's a surgical resection of the tumor, is a treatment of choice, and usually cures the hypertension. Careful preparative treatment with alpha and beta blockers is required to control blood pressure and prevent intraoperative hypertensive crisis. There are two causes of Addison disease. It's autoimmune, most common cause in developed world, or tuberculosis, most common cause in developing world. Clinical features are: the initial manifestation often include progressive weakness and easy fatigability, which may be dismissed, and non-specific complaints. Gastrointestinal disturbances are very common and present as anorexia, nausea, vomiting, weight loss, and occasionally as diarrhea. In patients with primary adrenal disease, there is increased level of POMC. It's a pro-opiomelanocortin, which causes increased production of ACTH and MSH. The MSH, melanocyte-stimulating hormone, stimulates melanocytes and causes skin hyperpigmentation. Sometimes it starts as freckles. The face, axilla, nipple, areolae, and perineum are particularly common sites of hyperpigmentation. Decreased mineralocorticoid, it's aldosterone activity, leads to potassium retention, hyperkalemia, and sodium loss, hypernatremia. Loss of sodium causes volume depletion and hypotension. Orthostatic hypotension, dizziness, and episodes of fainting are associated with adrenal crisis. Stress, such as infections, trauma, or surgical procedures, may lead to an acute adrenal crisis, manifest by vomiting, abdominal pain, hypotension, coma, and vascular collapse. Death follows rapidly unless corticosteroids are replaced intravenously. So, lab values: increased ACTH with low cortisol and hyponatremia, hyperkalemia, and low blood glucose. ACTH stimulation test reveals no rise in cortisol. And treatment: it's a treatment replacement therapy. For glucocorticoids, give hydrocortisone, and for mineralocorticoids, give fludrocortisone. For glucocorticoids, need to use stress doses for illnesses, surgical procedure, and hospitalization. Mineralocorticoids dosage may need to increase to 0.2 mg per day in the summer because of salt loss from perspiration. The term congenital adrenal hyperplasia gathers a group of autosomal recessive disorders, each of which involves a deficiency of an enzyme involving in the synthesis of cortisol, aldosterone, or both. Classic congenital adrenal hyperplasia is generally recognized at birth or in early childhood because of ambiguous genitalia, salt fasting, or early virilization. Non-classic adrenal hyperplasia is generally recognized at or after puberty because of oligomenorrhea or virilizing signs in females. Diagnosis could be 21 hydroxylase deficiency, 11 hydroxylase deficiency, low serum aldosterone, hyponatremia, hyperkalemia, and high plasma renin activity, and also use imaging for diagnosis. Treatment: long-term glucocorticoid and or aldosterone replacement, or both, depending on which enzyme is involved and or whether cortisol and or aldosterone synthesis is affected. Patients who are sick or have signs of adrenal insufficiency should receive stress dosage of hydrocortisone. It was adrenal disorders, and we talked about some conditions when there is a hypersecretion, hormones, or controversially there is insufficiency of these hormones. Anyways, thank you very much for watching, and see you next time.